everybody, welcome. This is Dr. Houman Danesh, and he is a physiatrist at Mount Sinai. Welcome.
Thank you. Thank you for having me.
All right, yeah. So excited about today's chat. Just a little background about Dr. Danesh. He had got his bachelor's in psychobiology from University of California and his master's in physiology from biophysics from Georgetown. And why don't you tell us? Why don't you fill it in?
I did my fellowship in physical medicine and rehabilitation, which is physiatry, which is what I shorthand call non-surgical orthopedics and neurology. So looking at form and function and how to restore patients to what they want to do from after they suffer from an injury. I then got a fellowship in pain management in the anesthesia department, where I learned to do all the different types of injections. And I'm also a licensed acupuncturist. So it's basically trying to find the way to get patients back on their feet.
Yeah, that's a much better intro than I was going to do. But I also want to say that Dr. Danesh is also very focused in kind of the integration between wellness, yoga, exercise. And so as a physical therapist, we really like that when we have a doctor that really values kind of our aspect of the medical wellness team as well. So that's a really cool kind of integration that he has in his practice as well. So happy to have the chat today. The goals today are basically to educate physical therapists and the patient population about specifically what physiatry is, and then focus on a couple different injection techniques that we can enlighten the public and the physical therapy profession about a little bit more specifically. What are the differences between these types of injections? We're going to cover facet blocks, medial branch blocks. We'll touch on nerve blocks, sympathetic blocks, review epidurals, and then we'll go to radiofrequency nerve ablation. So these are a lot of things that people don't necessarily know exactly what the population is that's most appropriate for these techniques, and specifically what they are. So let's jump right in. And let's start by just describing the actual procedures. So let's start with facet blocks. So walk us through what that is.
So let's start with the anatomy, because that'll basically show you the whole idea. This is a spine, and most of it's getting cut off, but this is a spine laying on the stomach. Now, this is the front of the spine. This is the back of the spine. These are when you run your hands down someone's back, you feel the bones on the midline. That's what you're feeling. The blue are the herniated discs. And then these yellow things sticking out on the side, these are the nerves that are going from the spine out to your legs in the lower spine and out to your arms in your upper spine. So your nerves are protected by a bony cage. There's bone in the front and there's bone in the back. And if you look all the way in the back, in this small little space, that's a small joint. So that's a joint in the cage that protects your spine. So a facet block or a medial branch block goes on the bony cage. So it doesn't go through, it doesn't touch any nerves, and what you're doing is you're targeting this bone. It's almost like a knuckle. An epidural, you go through the bony cage, either through these bones here or through this side entrance here, and at that point you're targeting a herniated disc that's hitting a nerve that usually goes to your arm and your leg. So I get a lot of patients that say, oh, I've had back pain because I have a disc bulge at L3 or L4, L3, L4, or L4, L5, and I had it 20 years ago. Thing about disc bulges is most of them don't cause pain. And if they do, that would be pain when you bend forwards. So, or when you sit for a long period of time. And quite frankly, that's not what most people have when they have back pain. Most people, when they have back pain, they have pain worse when you lean backwards. And if you look back at the bony cage here, when you lean backward, oh, I just broke the model, but it's perfectly okay. If you lean back, you're loading these joints to the point where you could break the model. But if you lean forward, you're opening up the space. And so you have to kind of take that into account. And the other thing I love to say is that an MRI is a sentence in the story. It's not the whole story. So if you try to look at a painting or a sentence in first line of Moby Dick, you're not going to know exactly what's going on. You need to put it all together with everything else that has happened to put the whole picture together. So a facet block, or a medial branch block, which is the same thing, is an injection of numbing medication over the joint. There can or cannot be steroids. An epidural goes through that bony cage and targets the nerves and the disc, which usually goes to the arms or the legs.
Yeah, I love that. That was a great explanation. I love how you touched on the MRI as well, because it's always important to associate clinical imaging with what the actual objective and subjective presentation of the patient is. So what does the patient report to you? What is their clinical history? And when you evaluate them in the clinic, what does that look like mechanically? And how you were talking about flexion during flexion versus extension, we know flexion is worse with a disc. Flexion is sitting. Flexion is bending forward. Extension actually is one of the treatments we can use for disc, because disc herniations are usually posterior laterally, and extension-based exercise usually can help centralize or move that disc away from the nerve roots. So that's one of the things that we do in physical therapy to treat discs. And when you're talking about kind of these more mechanical facet joint injections, these are for what we call somatic referred pain. So let's talk a little bit more about the difference between radiculopathy, which is kind of a nerve root irritation that's most common with a disc, which could travel all the way down the leg, versus somatic referred pain. So let's talk about that with regard to both the cervical spine and the lumbar spine.
Yeah, that's a really confusing topic, and patients get confused, doctors get confused, my fellows get confused. It's basically, nerve pain will usually feel like burning, tingling, numbness, and crawling sensation, and occasionally even cramp-like sensation. And it has certain patterns that if you know the way the nerve travels, you can then pinpoint whether it's a nerve or a joint. Joint pain usually is a dull, achy, deeper type of pain that's worse when you usually extend, or load. So depending on joints outside of the spine. So if, for example, you have this wire-like burning fire that goes down into your arm, into these hands, or into these 3 fingers, it could be carpal tunnel, which would be a pinch here, or it could be a pinched nerve in your neck, or quite frankly, that nerve can be pinched anywhere between the neck and the hand. And so the trick of this is to figure out where the pinch is and then unpinch it in one way or another.
Yeah. Yeah, and that's perfect. The diagnostic procedure is important here. There's some other ways that we can localize where
so yeah,
yeah.
Expanding on that, it would be like the joint pains in your neck. Traditionally, the C2-3 joint will actually go up to the back of your head and up to your eyebrow. And most patients will be diagnosed with migraines, and they think they have migraines. Treat this joint, this migraine that they've had forever is gone. And so the first part is to just put numbing medication. So that's part of the diagnostic way. You put numbing, patient has a headache or a migraine, gone. You do it again, because the standard practice is to have 2 diagnostic tests to make sure that just because the physician puts a needle in you, you don't get cured, which is called the placebo. But you do 2 of those tests, and if both times this pain that goes up to the back of your head to your eyebrow for a migraine, that's one joint, or pain between the base of your neck and your shoulder blades, or pain in your lower back that goes about into your mid hamstring area, each one of these joints has a different referring pattern. And so if you're suspecting that and it's worse with extension, you do a diagnostic injection. If the pain gets better, you know the pain is coming from that joint. What a lot of the physical therapists will notice is that when they're trying to release the levator scap, which inserts in the higher cervical regions like C2 to C5, or they're trying to repeatedly release the QL and lumbar paraspinals and the multifidus, they make sure that the other muscles like the rotator cuff are strong so the levator scap isn't working, and the glutes are strong so that the pelvis is stable and so everything else can release. Occasionally what's happened is the joint is so irritated and inflamed that you can keep trying to release it, but the muscles spasm back down over the joint to protect it. Because when a joint is inflamed, it starts rubbing against each other, and the muscles around it say, that doesn't feel good, and they clamp down. So you'll go in and you'll release it. You'll align everything. They'll do the exercises to keep it in place, but all of a sudden the muscle will spasm back down because these joints are now free to rub against each other. They rub against each other. They're inflamed. Muscle locks down to prevent that movement. What we do with the injection is oftentimes even the diagnostic injection, which is just local anesthetic, put it over the joint. The joint now calms down. It has a wash, and then the muscle doesn't spasm on top of it, and now you can progress in your physical therapy treatment.
Yeah, that's great. There's a ton to unpack there from both the medical side and the physical therapy side. So let's start with the diagnostic aspect and versus the treatment, because I think there's also some insurance hurdles, right? And we'll talk more about radio frequency and what the next step is and how to get there. But we're talking about the difference between diagnostics and treatment. Sometimes they're one and the same, but a lot of the time in the beginning here, as part of the diagnostic measures, these injectables are to understand exactly if we're targeting, localizing the right area of pain, right? And then
Absolutely.
when you're talking about the cervicogenic headaches, we call them cervicogenic headaches. They can be confused with migrainous headaches. You can have sinus headaches. There's a lot of different origins of headaches, but a lot of people have neck pain, especially with poor ergonomic setups during quarantine. We're getting more postural related issues in the head and neck. In physical therapy, we can look at this a little bit more objectively too. We know that the C0, 1, 1, 2, and 2, 3 facet joints usually refer to very specific patterns in and around the head. This is pain referred patterns. And we can actually treat it by mobilizing that specific joint with the specific techniques. They're typically unilateral headaches. You can have both bilateral symptoms as well with these referral patterns, but a lot of people don't think about injectables as treatments of headaches, and that's a very useful tool that we have now. So it was good that we touched on that, right? In terms of the treatments, let's talk a little bit more about what you do after these diagnostic blocks. Like what's next if we find out that, say, there are some pain referred patterns, whether it's in the in the neck and around the shoulder blade, or in the lumbar spine, that's not distal to the knee. We know that it's not discogenic. We're localizing. We've confirmed that it is referred pain from the facet joints. And these facet blocks worked, but the relief is somewhat temporary. So walk us through kind of what's next.
So the next step is to do first step is not just to do one thing. So the next step is a comprehensive pain program, which would involve physical therapy to target the supporting structures to make sure that they're strengthened, and anything that's tight to be loosened. And if you have limitations with that, you can do the ablation, which would be the radiofrequency ablation, which is the treatment injection. The needles go in the same place, right on the bony cage. And what you do is then you heat up the needle tip. What that does is that it shocks the nerve. I don't love using the analogy of a root canal because a root canal is so painful. But in a root canal, you have a cavity, you take out the nerve, and then you don't have pain. That's a permanent mechanical fix. What you do with radiofrequency ablation is that you are putting a needle directly next to the nerve and then heating up the nerve so that it gets shocked. And then 2 to 3 weeks later, the nerve starts to die back on itself, almost like a Persian rug. And as it's dying back 2 to 3 weeks later, it can cause a flare-up in pain. And most commonly, people get confused. It worked for 2 weeks and then it stopped. What happened? Well, the nerve is dying back. So it rolls the arm, it rolls it back to the body, and then it goes, okay, there was an error here. Let me fix it. It reprograms it, and then it regrows. So it takes about 6 to 12 months for it to regrow. And in that time, that nerve is not there to transmit the pain signal to your brain. And you really have to take the opportunity to strengthen and stretch and do everything and increase your mobility as well, so that when the nerve does regrow, it's not sending the same pain signal back because you've addressed it mechanically as well.
Yeah. A lot of this is kind of allowing physical therapists to progress with rehab where they may not otherwise be able to. And that's where the whole pain management model comes in. And it's not just manage pain, it's also kind of retraining these neural pathways. And you could think about the same way as like a hamstring strain. You irritate the tissue's healing, and when tissue heals, it heals in a cross-linked fashion, and it's not as extensible, it's more rigid tissue. And you need to work out the tissue, promote tissue extensibility during the healing process. So it's not just, treat the pain, let it heal. It's what can we do mechanically, biomechanically, and then, during the healing process to get the patient back where they need to go, right?
Yeah, and I think you're touching on something. Physiatry or PM&R and physical therapy were not two separate entities. It started in World War II when the veterans started coming back. The physician was managing the physical therapy, all the modalities, and anything else that they can do to get the patient better. orthotics, prostheses, everything. As the field has grown, and it's needed to almost branch. And so while physical therapy seems like a separate thing than pain management per se, you're thinking pain management, I have pain, I go to the pain doctor. Physical therapy, I go there to get my exercises better. They're really one thing. And it has to be a team approach, because if you only do one thing, it's not going to work, and you're going to hit a lot more limitations. The power of this entire field is when you put them both together, and how that exponentially magnifies what we both can do.
Yeah, and that's part of the point of these interviews here, because we really have to bridge the gap in the medical and the wellness community together, increase collaboration, coordination, communication. The channels are so disconnected in the history of our medical system, where, you know, a physical therapist would get a prescription, and then there's some, you know, the referring physician is too busy and not open to communication with the physical therapist, and there's a disconnect. Like, there needs to be a really connected, collaborative environment. You know, in some of these multidisciplinary practices, everybody's in-house, but that's not the case in you know, most of healthcare. So communicating with all your, you know, referring providers and your collaborative wellness team and medical team is so important. And this goes, you know, not just beyond, it goes beyond the medical side, the physical therapy side, all the way to the wellness. So, you know, there's also a disconnect between yoga, Pilates, and medicine, and even sometimes yoga, Pilates, exercise, and physical therapy. So bringing all that into an open line of communication, everybody understanding what the scope of everybody's practice is, what are the available treatments for a specific presentation, is just allows us to treat our patients better, right?
Yeah.
Yeah. So let's pivot. I want to just talk about, well, just before we leave radio frequency, there's a lot out there. A lot of people ask, we see a lot of terms: radio frequency ablation, lesioning, neurotomy. Are these all the same thing?
They're all the same thing, and they're all confusing when you hear it. All you're doing is you're heating up the nerve, and you reset. It's like hitting a reset button on your VCR.
So just for the record, just wanted to put that out there. Like, whenever you see the word radio frequency, with another word after it, it refers to what we just discussed here. So let's go to patient presentations. So we touched a little bit about the flexion versus extension, and somatic referred pain versus radiculopathy. But when we talk about epidurals, there's a hallmark of nerve pain that is from disc. Besides the actual the physical presentation where flexion's irritated, maybe the history is more traumatic. You can get degenerative discs as well that don't have trauma, right? But the pain patterns for a disc causing radiculopathy can be distal to the knee or distal to the elbow. Would you is that something you really look for, because to diagnose this? The difference between.
So it's interesting. We're always taught that below the knee is a disc, or below the elbow it's a disc. That's because about 90% of the cases, the herniations occur at the levels that go below the knee and go below the elbow. In reality, if you have sharp pain going into your groin that's burning, tingling, and worse with sitting, you really have to consider a disc in addition to the hip. So it's what you're looking for is a history, and the history can vary. It could be, I opened up a window and 3 weeks later I started having this pain. Sometimes you remember the trauma, sometimes you don't. What you really have to focus on is the nature of the pain. Is it a burning, tingling, ant-like sensation, hot wire? Hot wire is another big one. And if that's the case, and it's debilitating, it's definitely a disc. And when I mean debilitating, when I see these patients, they can't sit for their interview. They can't sit in the waiting room. That's a new hot disc. And an epidural goes a long way in calming that down. And if they have any weakness, like if they can't lift their foot off the ground, or if they're walking and it sounds like they're clapping all the time, and you're like, that sounds weird, they have a herniated disc that's hitting the nerve. And you have to think about, so what should we do? And that's when it comes into a team approach and figuring out the root cause and coming up with a custom program for each patient.
Yeah, and that comes down to, with physical therapy now, we see so many direct access patients. There are direct access laws where we get a lot of patients without referrals. So we need to differentially diagnose, and this is really important for physical therapists to understand too, is like how to identify that disc. And we're trained to look at dermatomes, myotomes. These are the effect on the sensory system, the motor system, the reflex system. That could be affected with some of these radiculopathy or disc-related nerve impingement cases. And then, of course, you'd look at the MRI, and then you correlate that diagnostically, and then you could go into the blocks, right?
Hey, here's a little clinical pearl for you. So the most common disc in the neck mimics carpal tunnel. So if they have numbness and tingling in these three fingers, how can you tell whether it's carpal tunnel or not? Well, the carpal tunnel sits about right here, and the nerve that gives sensation to this part of the thumb actually branches off before the carpal tunnel. So if this side of the hand feels the same as this side of the hand, it's unlikely to be carpal tunnel. Let me rephrase that. So if the nerve is pinched in your neck and it hits the nerve, and therefore it's numb, and it's not numb here, and remember, it branches before the carpal tunnel, so it should be numb. But if it's in the carpal tunnel, all three of these will potentially be numb. So to keep that in mind, the exam that you would do differentiates is basically the nerve pain is sensation. Sensation can be tricky. A lot of people will do light touch, but the gold standard is a pinprick. It has to be they have these special pinpricks that you can buy or use, or diabetic. They're like almost like a acupuncture needle. And as soon as it bends, that's the amount of force that you need to put. And then you put it on each side. If you don't have that, something more sensitive than touch is like a cold alcohol wipe. That'll also help you differentiate temperature as well as sensation. And those are the things that'll go first before motor weakness presents. So if you're picking up anything like that, no matter where it is, there is a nerve involved, and the question is where. If you have questions at that point, just refer it to a physician.
Yeah, perfect. That's great. So that kind of covers some more of the diagnostic aspect, right, of this. I want to just touch real quickly on sympathetic blocks. This is not commonly like a really common procedure. It's just something that people do read about when they do their Googling. So let's just differentiate real quickly for me what a sympathetic block is versus these facet injections and epidurals.
So they're done in a completely different place. They're all done in front of the spine rather than behind or on the side of the spine. And they basically are trying to quiet down your fight or flight response. So when you see a lion, you're running. And you're not sitting there being, oh, maybe I'll finish having this relaxing chamomile tea before I leave. Because that thought process is not in your body at all. And that process, it makes you run faster. It makes you more sensitive to pain as well in certain conditions. So if it goes haywire, that sympathetic response is constantly active and constantly sending pain, and you block that chain depending on what's hurting. Most commonly, you use it for complex regional pain syndrome. That's when there's traditionally pain out of proportion to the exam. There's redness, there's swelling. And the good news is in those situations, most of the cases get better on their own, about 80%. And the primary treatment is actually physical therapy. It's not the sympathetic injection. So the sympathetic injection is there to help the physical therapy get their work done, or to encourage the patient to be more not adherent, but more compliant with their physical therapy. So if they're saying, listen, this just really hurts too much, okay, we'll do a sympathetic block. There are certain things that you'll do depending on what part of the body. Legs has a sympathetic, neck and arm has sympathetic. You can also use it for vascular conditions. Occasionally you can use it for abdominal pain. But like I said earlier, it's about a team-wide approach.
I think just touching on that is important. It's definitely not something that physical therapists really are aware of, or for the most part that we commonly refer for. But just patients they get on Google and they see the word block, and there's all these different terms there. So that's great. So thanks for clarifying that. The patient presentation, I think is such a huge thing that we touched on today, which is like, I think the foundation of all this, because if we're talking about bridging the gap between the working on those communication channels between the physical therapist and the practitioner. It's all about what do we see in the clinic. And I think Dr. Danesh talked about like what these patient populations, right? If you see that new hot disc, right? Like flexion's painful, patient can't sit, they have a lumbar shift, that, you know, these are more obvious disc signs, along with some of the other diagnostic measures. Someone's older and you see, and there's no mechanism of injury, and they're getting, you know, typically referred pain, right? These are more maybe facet pain, or, you know, there, you could have also some degenerative foraminal stenosis, things like that. So looking at the history and then understanding what a physiatrist can do in terms of their injectables, both treatment, diagnostically, and then going and then moving down the chain into what's next, if there's efficacy there or if there's not, is just so key in the process of kind of referring back and forth. So
the key question that I usually get, and that was a very good summary, when can I do physical therapy after an injection? I get that all the time. And I'll tell you my view, and I'll base it in some science. So if you're getting a facet block, it's numbing medication for 6 hours. During that time, if you overstress the joint, you're numb. You're not going to feel it. And then when the numbing wears off, you're going to be miserable. So usually after the injection for that day, I don't recommend doing physical therapy. The following day, the numbing medication has worn off, so do whatever you want to do. So that's for the facets. RFAs, radiofrequency ablations, those can be sore. You might be limited in what you can do in physical therapy, but there is no medical reason to not do physical therapy. You may just not get what you're hoping to get out of that session, and usually you're sore maybe for that day or 2 days max. It's not something there. Epidurals get tricky. Epidurals, similar. You're getting a washout effect and you're getting a numbness effect. And so during that day, I usually don't recommend it. But the question then becomes, so when can you restart physical therapy? In short, the medication is going to take about 2 weeks to have a peak effect. So the numbing medication can work for a day or two, and then the numbing medication will wear off. And then the steroids start to work in 2 days with a peak effect in 2 weeks. So a lot of patients will think that they ruined the epidural by doing physical therapy 2 days afterwards. And they're like, well, I felt great, but then I did physical therapy and the pain came back. No, the numbing medication wore off. And so now you have to wait for the steroids to kick in. So really, I only limit you the day of the injection as far as physical therapy. There is no real reason to not to. And if you do happen to get worse, it likely wasn't from physical therapy. That being said, if there's a huge herniated disc and it's extruding and continuing to come back and it's causing multiple issues, you may want to take it easy and maybe just do some gentle nerve glides for a while, which a physical therapist, again, can give you. Or so that it's not, don't avoid going to the physical therapist. Just tell the physical therapist what you had done and have them communicate with the physician if there's any restrictions that they think they should employ, or just listen to your body. Ooh is okay, ow is bad. So
yeah,
those are general guidelines.
absolutely. And communicate with your physical therapist too when we're talking to the patient. You know, the whole no pain no gain thing doesn't fly anymore. You know, there's some diagnoses where, you know, you have a capsulitis on the shoulder in the end phases, and, you know, you need to get some range back, maybe you got to push a little bit. The majority of things that we work on in physical therapy, things that cause pain, cause an inflammatory process, cause more inflammation, cause more pain, and it's a cycle there. So communicate with your physical therapist. You don't, you know, a good physical therapist is gonna want to talk to you a lot, and is gonna want to hear how you feel, how you respond to treatments before, after sessions, during sessions. So that's key.
And don't hold your breath when you're doing the physical therapy moves.
Never hold your breath. Always breathe. We say that a lot. Even tougher, you know, that's always a challenge. We those are words that come out of our mouths quite a bit. But what any other questions that you commonly get?
No, I mean, the main one was usually physical therapy. Oh, is the injection going to hurt? It's a good one. Look, it doesn't hurt me. That's the first thing. And secondly, it's a injection. We numb you up, and it's the numbing portion. The mouth is the most sensitive part of the human body, and you get a needle in it when you go to the dentist. And again, I hate dental analogies, but And then you don't feel anything, right? The guy can yank your tooth out and you don't feel anything. I'm not doing anything that dramatic. We do use small needles. We do take every precaution. We're pain management. So we mix cocktails in a way to take away the pain. There are things that you can do to make it a more pleasurable experience. I'm totally open to patients playing their favorite song when they're in there. If it's a radio frequency ablation and they want to watch something because those take longer on their phone, go ahead. I mean, it's fine. But the main thing as far as pain, as far as the injection, look, most patients tolerate it well. Some patients become a little bit fluent in French. That's the way I like to call it. They all of a sudden they recall some French words they didn't know that they knew, but they're fine. Occasionally, patients is very painful, and we take precautions or steps to make them feel more comfortable. And then if that doesn't work, we can always add things for the future. We can always add Valium or Xanax to not relax the patient, which is what most patients think, but actually what it does, it relaxes the muscle so the needle goes through the muscle easier. It's like leaving a stick of butter out before you use it. It's smoother and easier. You could use it right out of the freezer. It's just going to be a little bit harder. So if you're having any sort of issues, a muscle relaxant, I call those, because, by the way, total tangent, there's no such thing as a muscle relaxant. There's one such thing as a muscle relaxant, is used by anesthesiologists when you're operating. Muscle relaxants are just milder forms of anxiety medications, because they both work on the brain. And when the brain is relaxed, the muscles relax. So you can always say, hey, again, just like when you speak up with your physical therapist, speak up with your doctor. And if you say, listen, is there anything you can do to help me relax a little bit or to release the muscles a little bit before the procedure? Yeah, we give you a pill 20 minutes before. You have to fill it yourself. We don't give it to you. We write the prescription, you take it, and it's more tolerable. And that's a rare thing. Most patients, perfectly fine, no problem, maybe a little sore. You can add some ice afterwards. Maybe. Rarely is that an issue, though.
Yeah, I think kind of eliminating some of the stigma behind some of these, the injectables in the process, and just understanding what the actual procedure is. And we didn't really talk about kind of the actual, some of the, how we do it. It's fluoroscopy guided, right? So these are very specific guided injections. People aren't just taking a needle and shoving it in your spine, if you can understand a little bit more, like we talked about the procedures, what we do before the procedure, after the procedure, how long it actually takes, like we talked about today, the stigma is gone, and these treatments become a little bit more accessible to you. It's not getting some, even as a physical therapist, we want to promote and non-surgical management. That's why we love physiatry. And it's not a cop out or a failed physical therapy if your patient needs an injectable. This is a collaborative environment that could allow us to rehab the patient better without the compromising pain that and the pain patterns that they're experiencing. So
there is something to say that intervening earlier is better. Once you're in pain for 3 to 6 months, your brain actually reorganizes, and it becomes harder to deorganize your brain.
we could have a whole nother conversation.
Yeah, that's not quite the word, and there's a whole yes.
Yeah.
So if you're even if you're not struggling, if you're doing the same thing session after session after session, 3 or 4 sessions, and you're not progressing, an injection may help to break that cycle.
Yeah. I mean, we just touched on pain science there. That's a whole nother world, and it's such a powerful thing. Your brain's influence over your body, and these are not fake symptoms. These are real neurochemicals, neurotransmitters are influenced by perceptions and cognition. So that's something that your physical therapist can actually talk to as well. And so we do it in the clinic. We bring that up when we're talking about pain management as well. So it all fits in the puzzle. So, but yeah, I think that was great. Anything to sum up? I think we covered a lot of great stuff there.
No, I think this hopefully will be useful for physical therapists and patients alike. And that's all I can say for now.
Yeah.
Thank you for having me.
Yeah. Thanks for being here. And so we'll have Dr. Danesh's info below in the comment section in the video. He's in the Mount Sinai system on 57th Street, right?
57th and 7th and 98th in Madison.
Yeah, perfect. So we'll get your info and contact info below. And It's been a pleasure, and I hope this was informative for everybody, and looking forward to the next one.
All right.
All right, thank you.
Take care. Bye-bye.